Good afternoon, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. This is going to be our committee orientation today, and we're delighted to have the Department of Health and Human Services, the Commissioner, and various others with us, as well as Division 3 of Finance. Before we get into the proceedings, however, I would ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Before we welcome our guests and have them come up and talk about the department and various other matters, I'd like to go around the room and have the committee introduce ourselves to the audience before the audience introduces themselves to us. My name is Wayne McDonald. I have the privilege of being the chairman of this committee. I'm in my third term in the House, and I represent the town of Londonderry, which is Rockingham County, District 16. Representative McGrath.
First-time rep from Hampton Seabrook, Ontario, District 40.
Turn on your microphone.
Put your microphone on, please, Representative McGrath.
There's one right in front of
Okay. Representative
me. I
Hartnett.
talked loud enough, I think.
Good afternoon. I'm Tim Hartnett, first-term representative from Manchester, District 41, wards 2, 4, 5, and 7. For those who are not familiar, it's really the east side of inner city Manchester.
Representative Drew.
My name is Matt.
When the light is on,
Red.
it's
Touch it once and then it'll say.
There you go.
there you go.
The red light.
You're all
Okay,
set.
yeah.
Yep.
My name is Matt Drew. I represent Ward 10 in Manchester on the west side.
Representative Woods.
Good morning. I'm Gary Woods. I represent Merrimack 30, which is wards Floterial, wards 5, 6, 7, and 8.
Thank you. Representative DeLamus.
I'm Sue DeLamus from Farmington, New Hampshire, District 1. This is my second term in the HHS and my fourth term non-consecutive in the House.
Thank you. Representative Weber.
Thank you. I'm Lucy Weber. I represent Cheshire District 5, which is the towns of Walpole and Surrey over on the Connecticut River, or at least Walpole is, and Surrey's right inland from that. And I'm starting my 10th term in the House, which is a matter of some astonishment to me.
Thank you. Representative Mazur.
Thank you, Mr. Chair. My name is Representative Lisa Mazur, and I represent the towns of Goffstown and Ware, which is Hillsborough District 44, and this is my second term. Welcome, everyone.
Representative McKay.
Thank you, Mr. Chairman. I'm starting my 28th year, and most of them has been on this committee. And I have the unusual opportunity that most of them don't have. I represent the State House. This is right in the middle of Ward 4 in Concord.
Representative McLean.
Mark McLean, representing Ward 8 in Manchester. I make light bulbs, which doesn't have a lot to do with HHS, so I ask stupid questions sometimes, and I apologize in advance, but I'm just trying to learn.
Representative Lamontagne.
Hi, I'm Jessica LaMontagne from Dover, which is and represent Ward 5, which is Stratford County District 17, and I'm in my second term in the House.
Representative Polazov.
I'm Yuri Polozov, representing Merrimack District 10, Hooksett and Dunbarton. It's my second term in the House and second term in this committee.
Thank you. Representative Palmer.
Hi, I'm Bill Palmer. I represent Cornish and Plainfield, which is Sullivan District 2, and this is my second term.
Thank you. Representative Markell.
Yes, my name is Jay Markell. I represent Atkinson, New Hampshire, which is Rockingham County District 18. This is my first term.
Thank you. And last but not least, Representative.
I'm Janet Lucas. I represent Grafton District 7, that is the town of Campton, and this is my first term.
Thank you all, and welcome everyone. Welcome back to the returning members, and welcome to the new members, and I look forward to working with all of you. With that, I would ask that we begin, and I'd like to recognize the Commissioner of the Department of Health and Human Services, Laurie Weaver, to come up. Thank you for being here, Commissioner.
Good afternoon. Thank you for having me and my team here today to speak with you about the department, who we are, and what we do. So, as Representative McDonald had said, my name is Lori Weaver. I was thinking I'm in the middle of my term, which is 4 years. I've been with the department for 28 years this year, going into my 28th year. Not all as commissioner. I don't think anyone could survive that. But really coming into the department and leadership positions, and in those 28 years, various roles in the department. And then in 22, became interim commissioner, and then 23 became permanent commissioner. So I do have some familiarity with the department. There's no stupid questions, so please do ask us all questions. I am bringing some materials to share with the assumption that some of the community members are new and may need to know or would like to know a little bit more about the department. The department is large, but it is not something to be afraid of, in the sense that people always say the department is large and not knowing what that is. It's actually hoping today to put that into some bite-sized pieces for you to digest. 2 years ago, I believe I was here for a meet and greet, and at that time, I had my strategic priorities for the year of 23, when I was interim commissioner, what we called our roadmap. So that was basically our strategic plan. So what I'm sharing with you today is our 24-25 roadmap.
Commissioner?
Yep.
Do you have any extra copies? I don't think we got enough for this side of the room. Or did everyone get one of these over there?
The issue is the clerk needs copies, and we need copies for the two people who are not here.
And I will get those. We will follow up and get those for you. The
thank
good
you.
news is it's also on our website, so folks in the interim, of all of that, I wasn't quite sure of the total number of members.
Thank you.
I know that a lot of my staff are here today to be able just to say hello to you and give you an idea of who they are, names with faces, and the areas that they cover. What I wanted to do with you is just to sort of explain the department a little bit at a high level, and then share with you what our priorities are for 24 and 25. So I'll start with this sheet here that is the 2-pager. This basically is sort of the Cliff Note version, if you will, the cheat sheet about the department. So at the very top, we have our vision, which is, it's really quite simple: optimal health and well-being for everybody. Our agency is charged with serving our vulnerable populations in the state, and we aim that all of our citizens will have optimal health and well-being. We have our mission statement, and then we have some of our values. We also have what our primary responsibilities are. So what does the department do? What are we mandated to do, required to do, whether it's federal or through state? So protection and prevention. So you'll have heard a lot about child protection. There's also adult protection services, health, disease. Obviously, Medicaid is one of our major funding sources that we use to provide a lot of the program services that we have. Client service delivery, we actually have about 50% of our workforce is what we call direct care, and that is providing either some form of case management services. So you'll think of a child protective service worker or adult protective service worker, maybe a child support officer or an eligibility worker. But we also have 24/7 facilities. We currently have 4 of them, and one is in the process of being transitioned over to a different provider. I have staff that provide services. So we have some nurses, we have physicians, we have clinicians. We do contract out some of the clinical services of that, but we have a robust workforce that provides the day-to-day skills needed, whether you're in a geriatric psychiatric hospital such as Glencliff, or you're in New Hampshire Hospital. We have mental health workers, we have LNAs, we have food and nutrition, and so on. We also have our youth development Services Center, which is down in Manchester. So we have direct staff, staff that provide direct services down there as well. So it's pretty robust. And we also, because it wouldn't be government without regulatory oversight, we also have that as well. So when you think about our nursing facilities, our childcare facilities, our food, right? We do food licensing, restaurant licensing, our nursing facilities. So we work and go out and do reviews as to make sure that they're following what they're supposed to be doing in their regulations. So that's a big part of HHS. Trying to break it down into sort of a palatable, if you look at it, I've listed and given a little bit of a narrative of each of the divisions. So it's about 8 divisions total. 6 of them are about programmatic, direct policy areas, and 2 of them are really supportive, which is like your finance and procurement, and then our quality improvement and assurance function. So we have behavioral health, we have DCYF, we have economic stability, long-term support services, Medicaid, public health, and of course, I mentioned quality and finance. What I want to point out is it seems like a lot of divisions, but if we think about who we're serving, it's the families and the kids. So all of these divisions wrap around those people that need services. So it's not siloed and segmented. And if it is, we work to try to fix that. But the point would be is that the staff from each of these divisions work together collectively in an integrated fashion to integrate policy, to integrate financial supports, to integrate case management services, advocacy, you name it. So those pieces all fit together in a choreographed way. It isn't just these random, we'll add another one on. And so we have our finance folks to keep us in check to make sure that we're not spending more than we have been allocated or authorized to do. And then we have our quality folks who basically are saying, are you doing it the way that you're supposed to be doing it? Are we accountable to those such as that give us the funding source? Are we accountable to those that we serve? Are we doing our due diligence in serving the people of New Hampshire? So that's sort of how all of those pieces work together. My job is to make sure that all the pieces continue to work together and that all these divisions are effective, that I have good leaders that can lead each division, that hire good staff to provide those services. And I sit here in front of you today to tell you I'm very proud that I have an excellent leadership team, many of whom you'll be working with throughout session, and you'll get to know them. And they make themselves available to you whenever you have a question, whatever that might be, meet with you whenever you need. So we are here and want to be that resource to you. I'll stop there before I go into roadmap to ask if there's any clarifying questions on structure.
Any questions? Any questions from Division 3?
Just a small one.
Representative Edwards.
On this, Madam Commissioner, on the list here of the department leads, I don't see Patricia Tilley. Am I blind or is she not on here?
Well, I don't have the same list that you have right now, so I couldn't tell you if you're blind or not.
That's the second.
That's just our.
Oh, no. So the list that he's referring to is a list of what we have for meet and greet today. We did not get rid of Patricia Tilley. If she left, she didn't tell me.
I was hoping she'd buy me a beer.
Yeah. Well, that's a conversation for another time. So we have leadership infrastructure, which Trish is part of that, as well as some other folks that help assure all of what I was just saying to make sure that we're providing and doing what we're supposed to be doing.
Okay, thank you.
Moving to the roadmap, on the back of it is sort of, again, it's the Cliff Note version. The reason I shared this is to give you an idea of the depth and the breadth of when we're talking about goals, what are we actually looking at? So that's great that you're going to improve customer service, but what specifically are you going to be doing? So let me just walk you through the 3 circles. We pretty much put it into 3 commitments, which break down into 15 initiatives and 43 goals in its entirety of the roadmap. So our first, I'd like to start with the darker bubble, which is invest in people and culture. So it has been a priority of the department that we can't, and that they're staying and that they're doing good quality work. So you need to invest in that in order to be able to do that. Second, purple bubble is our promote thriving communities. That's where the bulk of our policy work is and our program work. So you'll see some examples down below there of initiatives that are happening. So if you look at Mission Zero, I'll give that as an example. Some of you may or may not have heard about that on the news. That's our ED boarding. That's our emergency department boarding. So we knew a couple of years ago, there was some litigation. There's always litigation. We didn't do it because of litigation. But there's litigation to clear out emergency rooms and not have folks wait there. We all want the same thing. We don't want folks sitting in emergency room either. We created Mission Zero, which basically was a concerted effort to reduce that number. And through particular interventions, I'm happy to say to you today that we have reduced significantly not only the number of people that are sitting in EDs, but the time that they're sitting there waiting for a bed. So that has taken a lot of work in terms of resources and system transformation, but partnership outside of the department. We had to actually partner with our hospital association, with our providers to be able to say, how do we work together to make a dent here? And we have. We made a significant dent, and we have that 6 core strategies focused around that. So that's not just the front door. It's also when people are leaving care, do they have a place to go? Do they have a place to live? Can they sustain and stay there? So you can read about that in further depth within the document itself. And I'd be happy to talk to any of you about that as well. We also have a couple other things on there. There's issues around lead. There's issues around, one of our issues is healthy mothers, healthy babies, really making sure that people are getting the care that they need before they give birth, when they give birth, and postpartum as well. Our disability system, developmental disability system as well, strengthening that, making sure that folks are getting the services, the right services that they need when they need them. Access to community care, whether our system of care is whether you're a senior or whether you're a child or a youth or an adolescent, we have systems of care that we are responsible for standing up and running to service those needs. So that's a real chock full. I won't go through all of them. Like I said, it's in your packet. But that is what we're focusing on and striving. And when we look at our budget and we look at our budget priorities back up these initiatives and the things that we know are going to make a difference to the people in our state. So they're getting care when they need it. They're not getting it languishing away in care if they don't need it, and that they're in community as much as they can be. The last bubble is improve customer service. We have, as you can imagine, a big reach in terms of who we serve, and I need to make sure that we as a department are responsive, not only to the people that we serve, but all of the systems that are tied in with that. So making sure that it's easy for families to understand how to navigate the department, making sure that it's easy for our provider network, who we rely on to do a lot of our services. We draw down money from the feds. We don't necessarily provide the service. We need somebody to be able to do that. We have to have good relationships with our providers to do that. The procurement process for the state, it's long, it's cumbersome. We're working to improve that. So if you wanted to, as a provider, bid on a contract, it shouldn't be harder than it is to provide the service. And sometimes historically, it's been that way. So for the last 2 years, I've partnered with our Center for New Hampshire Nonprofit Association to be able to engage our folks and say, how can we do this better? How can we make this easier? So that partnership and that collaboration is extremely important. So, and constituent complaints, I receive many in a day. I read all of them. Respond to all of them as quickly as we can and as thoroughly as we can, and try to take the information and feedback from that and to do some improvement so that's not continuing to happen. So this is what we're keeping our eye on over the next 2 years. This is a 24-25 roadmap. There are some things in here that are longer term. There are some things that are shorter term. So what we'll do this spring, we'll revisit where we're at. We have quarterly progress reports to look at where we're at, and then we'll course correct, and then we'll set out another roadmap probably in the beginning of the summer as well that will chunk out for the next year. It's sort of the easiest way for us to sort of lay out the work and then attack it, and then also have some wins along the way. So I know I've said a lot, and I know I talk fast. Are any questions?
Any questions from the committee? Division 3, no? Commissioner, thank you very much.
No?
Apparently, no one else is missing that on the list.
Thank you very much for your time. Nice
You
to
can only
meet you
drink
all.
one beer, so Okay, next on the list I have, and I'm Ian Watt? Yes. Sure, that's fine. That's fine, Representative Edwards. Good afternoon, Mr. Watt.
Good afternoon. Thank you to the committee for having me here today. My name is Ian Watt. I'm the director for the Division of Public Health Services. I've been with the department since 2021. I've been serving this role since the beginning of last year. I want to just go over today a little background on the Division of Public Health Services. We are split into 7 bureaus with the primary goal to protect the health of all people and communities in the state of New Hampshire where they live, work, and play. Public health improves quality of life, helps children and families thrive, and prevents human suffering with a focus on activities and programs that prevent disease, prevent injury, and prevent death. The work of public health is data-driven. We use data to focus the resources available to us to be most effective in serving our residents and to educate people about ways to stay healthy and provide science-based solutions to health-related challenges in New Hampshire. Our staff consists of a range of professionals, including physicians, nurses, epidemiologists, health educators, restaurant inspectors, social workers, evaluators, nutritionists, data analysts, scientists, and laboratory workers. Public health promotes programs that protect the health of our citizens, including preventing the spread of disease and understanding and investigating its prevalence. By example, in the case of an instance of tuberculosis in our state, our public health nurses would coordinate with a patient to ensure that they receive appropriate care and information around their condition. We would also then coordinate with the community and any potential exposures to make sure that anyone else who may have been exposed would be aware of potential health risks and also have access to information and resources to enable them to stay healthy. We educate people about the risks of chronic diseases such as diabetes and cancer. We work closely with community organizations and healthcare facilities to ensure that vulnerable and at-risk individuals receive access to timely cancer screening and are aware of programs for eligible individuals to receive preventative care services that maintain their health and save costs and capacity in our healthcare system. We also help prepare for and respond to public emergencies and health emergencies. This includes, as part of our partnership with the Department of Safety and Homeland Security and Emergency Management, working as part of the State Emergency Operations Center, where we support shelter and medical care needs in the event of a public emergency. Public health includes programs that increase quality and access to healthy foods and quality health care. By example, our WIC program serves more than 16,000 low-income women and children under the age of 5 to ensure access to nutritious food to allow their families to thrive. We also work closely with our community health centers, including our federally qualified health centers, to maintain access to basic health care services across the state for low-income, vulnerable, and rural populations. We also include our State Office of Rural Health and Primary Care, working with partners in the community and our healthcare facilities to ensure adequate recruitment and retention of the healthcare workforce we need to serve the people of New Hampshire. These are just a few of the ways that we serve the public, as well as public health impacts for residents. Finally, I wanted to note that public health also includes our public health laboratories, whose mission is to protect the public's health through responsive, unbiased quality clinical research and environmental testing. The public health has a range of services available. Among them are well water testing, which allows homeowners to test their well water and confirm their access to safe and potable water. We also participate in national food surveillance networks to identify potential food contamination in our food supply and ensure that any food reaching our tables is safe and healthy to eat. During this session, you'll be hearing from a range of our staff, not just myself, on bills covering topics such as maternal and child health. We always endorse to ensure that moms and babies across our state receive the utmost care and attention from our healthcare system and other programs. You'll hear from us on various immunization bills to ensure that we maintain access for all children and families to routine life-saving immunizations. You'll hear about our therapeutic cannabis program. Therapeutic cannabis is a public health program which serves approximately 15,000 patients and caregivers, including veterans, cancer patients, and people suffering from chronic pain. And finally, you'll hear from us on a number of environmental health bills, including lead poisoning prevention-related bills, to keep ongoing attention on lead hazards in our communities and ways we can keep our families and children safe. And finally, I want to make sure that I have a chance to introduce a few members of our team who were able to join us today. I'm not going to look backwards the whole time, so I'll trust them to stand up as I introduce them. I want to start with Courtney Keene, who is our Bureau Chief for Family Health and Nutrition. Family Health and Nutrition includes our nutrition programs such as WIC, as well as our maternal and child health programs. Chawei Chawla. Chawei is our Bureau Chief for Public Health Statistics Informatics. She is our data lead for the division focused on data privacy and data security. I have Michael Holt joining me. Michael is our administrator for the Therapeutic Cannabis Program. You'll hear from Mike on a number of the bills related to therapeutic cannabis access. And finally, in person here today, I have Abby Rogers with us. Abby Rogers is our legislative liaison. I'm sure many of you are familiar with Abby. She is an enormous resource internally to our organization and certainly to you all as a coordinator, as well as an expert in a number of our programs. Not here today, I did want to quickly mention our Michelle Roberge, who is our Public Health Protection Bureau Chief. That includes our lead program. Colleen Smith, who is our Infectious Disease Bureau Chief, and Whitney Hammond, who is both currently our Bureau Chief for Prevention and Wellness, which includes chronic disease, as well as our Interim Deputy Director. You'll also hear from Dr. Ben Chan, who is part of our Public Health Division. Dr. Chan will appear in front of you to talk about a number of the immunization bills. And that's all I have for presentation, and happy to take any questions or other inquiry.
Sure, thank you. Did I see a hand up over here? No, I guess I didn't. Yes, Representative Woods.
Thank you. Just a very quick question, overlapping with the PFAS Commission. When you are testing wells, do you work with DES in terms of sharing data relative to lead, but also PFAS?
So it would depend on the program and the inquiry. In order to share data due to the necessity of maintaining privacy and health information, we may need an agreement with DES, but certainly we work with them to ensure that data is shared where relevant and appropriate.
Other questions? Representative Edwards.
Thank you, Mr. Chair. Do you think you have a few minutes during this session for me to introduce the Division 3 people and explain why it's important that Division 3 and HHS know each other?
Sure, after Mr. Watts is done.
Yeah,
If you want to do that.
any
before we
time
have
in
the
your
next
hearing
person
is
come
fine,
up.
sir.
But anything else for Mr. Watts? Representative McKay.
Just a very brief comment about Michael Holt, if he'd stand up again. He was with me on the 5 years that we had to deal with medical marijuana. That was one of the most, I'd say, educational opportunities. It was painful at times. And Michael was extremely helpful. And anybody that wants to know anything about marijuana, he's the man to go to.
Thank you. Yeah, Mike is a tremendous resource. Thank you very much.
Anything else from Mr. Watts? Don't see anything. Okay, thank you, sir.
Thank you.
And Representative Edwards, if you want to briefly introduce Division 3, sure. Go ahead.
Thank you so much. As a former member of Health and Human Services Committee, I really appreciate your hospitality of bringing us in. I think over the years we've figured out that for freshman legislators and new people to the two committees, Division 3 and HHS, that it was important to share a general philosophy of how HHSEA is the policy committee, and if this committee sees a good policy and it gets it through the House, if it's got a fiscal note, if it spends money, it'll come to Division 3. So we're like two sides of the same coin. Your policy, we're finance. There's always, I think, been a handshake agreement that each of our committees would work together, talk to each other, get to know each other's members, collaborate, and have your committee also concerned about fiscal responsibility, and our committee being appropriately concerned about whether policies are sustainable. And somehow we've figured out how to make it work for the last few years. That's why I think it was important to have Division 3 here, so that they can learn about the department. Some of them are brand new to us. At this point, I'd like the Division 3 members to stand up and speak up and introduce yourself. And you could start, Representative Priest.
Manchester, representing Hillsborough District 17. Representative Gary Daniels from Milford. This is my 10th term in the House. I was 9 terms on the Labor Committee, and I was in the Senate for 6 years. 4 of those years chairing the Senate Finance Committee. Now I'm back in the House.
Brian Seaworth, I represent the town of Pembroke. I was only 6 years on the Labor Committee, and this is my first year.
Representative Rich Nalavenko from Cheshire District 9, representing the towns of Elspeth, Gilson, Harlow, and Stoddard. This is my first term. Jerry Stringham from Lincoln and Woodstock. This is my 3rd term and 2nd.
Walnut is my 26th term. Been told I'm to be in the House, and I've been on finance. Laura Swirsky, representing National 14, 11.
And so the only one that's not here is the Division III Vice Chair, Representative Maureen Mooney from Merrimack. She's been a vice chair now for, I think this is going to be her 3rd term on Division III. And she would be here, but she had to get home. I think she's watching us on TV if anyone wants to wave to her at home. But so thank you, Mr. Chair. I really appreciate the cooperation and having us get off on the right foot for the coming term.
Sure. Thank you, Representative Edwards. My pleasure. Okay, moving on. Next, I have on the list Ernie Gillan. Or Gillen? I apologize if I mispronounced that name. Is it Gillan or Gillen or?
I think somewhere in there it came out right.
Okay.
It's Gillen, actually. So I'm Ernie Gillen. I am the Director of Information Services at the department. I've been with the department for a strong 5 years, and I became director in November of 2024. So today I wanted to talk about a little bit, as you are certainly aware, technology is an integral part of every service the department has to offer. Therefore, making it significant in how we approach all our solutions. I want to talk about the areas that comprise information services for the department. That is project management, enterprise business intelligence, information security, department technology strategy, and support services that go along with that. I'll talk to you briefly about functions of each of those areas. So with the project management office, that really is operated for our Center of Excellence for Project Management. Project Management Office spends a lot of time educating and developing project managers at the business level so that we can be significantly efficient in how we get our projects accomplished and turn those into services. Project management is responsible for portfolio governance services and methodologies that strategically address the highest priorities of the department. Enterprise business intelligence is our area where data management, data governance, data analytics, and data warehousing and reporting needs are accomplished. Information security is our information risk management, security and privacy education and awareness, security incident response and management, and system privacy and security. From an IT strategic...
Could I interrupt you just a
Sure.
moment?
It may just be me, and tell me if it is, but could Mr. Gillen speak a little closer? Just pull the microphone a little closer.
Absolutely. Is this better?
Yeah, and it's not just for us, it's for the people who are watching at home.
Excellent. Thank you.
Thank you, Representative Weber.
And I'll go do a hearing check.
So from an IT strategic standpoint, our approach is to help across the department, as our customers are not only the department as a whole through every program area, but also everyone that they serve. So we approach solutions in a way that is privacy centric and can make more efficient and quicker accomplishments to deliver those services as well. Some of the support services as you might guess, would be asset management. In other words, the handling of all the equipment needed for our staff and needs across. Information Services has a strong collaboration with the Department of Information Technology. We partner across in almost every aspect that we have with that separation, but we're really become one team in that delivery. Any questions I might be able to answer?
Any questions from the committee? Seeing none. Okay.
Great. Thank you very much.
Thank you very much. Next up is Karen Hebert.
Good afternoon.
Good afternoon.
My name is Karen Hebert, and I am the Director for the Division of Economic Stability. I'm very happy to be here this afternoon for you. So the Division of Economic Stability in DHHS, the mission of the division is to enhance the health, economic, and social well-being of individuals, families, and communities. So we have a number of values and anticipated outcomes that we strive for. It includes that individuals and families have access to a means to acquire life necessities, some who need it permanently for a lifetime, others who may need it temporarily. This can include healthcare, utilities, food and clothing, and becoming healthy and financially stable. We strive to support working individuals and families and help them to acquire and sustain gainful employment to become self-sufficient and financially more secure. We work to reduce poverty and prevent poverty and the need for public assistance. We promote responsible parenting, family self-sufficiency, and child well-being. We seek to provide access to services of high quality, reliable child care for working families in the state. There are 5 bureaus of this particular division. The first one is with respect to child development and the Head Start Collaboration Office. And this program establishes means to creating a landscape where every family can access diverse, affordable, and culturally responsible childcare options that best meet their needs. We provide child support services. This is encouraging responsible parenting, family self-sufficiency, and child well-being by providing services to locate parents, establish paternity, establish, modify, and enforce child support obligations, and we obtain and collect that child support, and we enforce medical support for children as well. We provide employment support services for people, assisting parents with upward economic mobility by providing work or promoting work through a provision of employment support and training services that will strengthen families, improving child and family well-being. We also assist individuals and families to gain access to and determine eligibility for medical and economic assistance programs. This includes the Supplemental Nutrition Assistance Program, also known as SNAP. It includes the Temporary Assistance for Needy Families Program, known as TANF, a number of state supplemental programs, and we also determine that eligibility for those programs as well as Medicaid. We work very closely with our other divisions across the department. We have very strong collaborative relationships with all of them. We also work very closely with our community partners who play an essential role in delivering our services. You will see me here before you when there are needs to provide you with information or respond to questions about legislation regarding childcare, family assistance, and employment supports. Child support services are typically heard by the Children and Family Law Committee, but if there are questions of any of you, you'll certainly see me here. You will also see our legislative liaison. His name is Brian Clark, and I'm sorry he couldn't join me here today because he is actually participating in an administrative appeals hearing. But with me today, I do want to introduce, I'm pleased to introduce to you the Deputy Director of the Division, Tina Cabana. And I'm also pleased to introduce one of the Bureau Chiefs that you may see from time to time when it's needed, which is Deborah Sorley from the Bureau of Family Assistance. The other thing that I can be of assistance to all of you for are any inquiries from your own constituents. If you have individuals who have questions or particular needs about eligibility programs such as Medicaid or other family assistance programs where they just need help, I am available for you to provide you that assistance and support for getting what those individuals need. So feel free to reach out to me at any time. Happy to answer any questions.
One observation I have, as you may know, I worked for the department until 2019. And I think back then, and I'm not sure when it changed, but child support was a division unto itself at one point. And so was, I think, family assistance. So it's interesting to see how the structure has changed over the course of time.
That's correct.
Any questions from the committee? Representative Edwards.
Thank you, Mr. Chair. This may not be the right question for Ms. Hebert, but with the commissioner gone, I hope somebody can answer it by the end of the meeting. We've all been doing this. Many of us have been doing this for many years, and occasionally we'll get a constituent. I'll call it a complaint. There's probably a better word, but sometimes you get a constituent complaint. And as a legislator, I don't want to get involved in the personal information, but nevertheless, I want to be able to do my job of handing the issue off with, some specificity to just have the department doing its own independent look into whether or not we did our job right. Because it's a big organization, lots of people. We don't do everything perfect. So occasionally it's worth an independent relook. What I would like to know is, as one of the many legislators that may have individual cases brought to us, what is the methodology we should use to turn this over to a responsible, accountable individual who could ensure that a relook is done properly? And again, I don't want personal health information. I just need to know at the end of the day, do we think we did this right? And if we didn't, are we working to resolve it? I kind of need that sort of binary answer.
Thank you for the question, Representative Edwards. So I receive inquiries from many frequently, and Mr. Williams is also available and receives some of those inquiries, which he often forwards to me. Mr. Lippman also receives inquiries that very many of them get forwarded to me to address. I would not provide you with detailed information about those individuals. My role is to make sure that their needs are addressed, their questions are answered, and that they have the information that they are looking for, that we take care of them.
So for clarification, regardless of where in the department the complaint might best be sourced, you would be the front door, you and Mr. Williams would be the front door for the entire department, and you will sort it out on who should be looking into it?
We can absolutely do that for you.
That's outstanding. Thank you.
You're welcome. Thank you anyway.
Any other questions? Seeing none, thank you very much. Next individual is certainly no stranger to this committee. Welcome, Henry Lippman. Between Oversight Committee and this committee, I see a lot of you, and you probably see more of me than you want to, but please put your microphone on.
That's not true. I'd be glad to be here anytime. Thank you.
Well, good to have you.
Thank you. Just to open it up, I'm Henry Lippman. I'm the state's Medicaid director. I've been in that role now a little over 7 years. I report to Ann Landry, who is the associate commissioner, and I will introduce more of the team as I go through the little slide deck I have here. The walkaway piece that's being handed out right now is just so you have a reference if you want to put it in one of your notebooks or something, so you know how to get a hold of some of the key people in the Medicaid division. So I think it can be a little bit confusing of like who to go to for what, and I'm glad that Karen spoke to that. But the Medicaid division provides a service which you probably be more familiar to most of you, which is the health insurance part of what we provide, the Medicaid program, what you would probably recognize as being the typical thing when you have your own health insurance. We also provide financial, technical resources to support other divisions, and I'll go into that a little bit more in a moment. But just in terms of the sort of the heads of the Medicaid team or myself from the program standpoint, I'm on slide 2, and Athena Gagnon, who is the Medicaid finance director. I've included below that more probably for Division 3, kind of where you might find some of the key financial unique identifiers. In terms of the policy team leads on slide 3, David Chorney is the Deputy Medicaid Director, and there's a lot for us to cover in the legislature at times, so either one of us, I think, can handle any of your questions. If we don't have the answer, we'll certainly come back with it researched. Olivia May is our Director of Medicaid Enterprise Development, and really what that is making sure that both from the technology side and from the different program areas that we're integrating appropriately with like the various divisions within the department, particularly as they use Medicaid funds. Rob Berry, I believe, is in the back here, who is our Medicaid legal counsel. Dr. Finney, who's our Medicaid medical director. I think a lot of you know her. A piece of news, which is good for her, but not great for us, is that she will be retiring in the coming year here. Dawn Landry, who is our policy administrator. I know she is not here. Peg Clifford and Lisa Ferran are our pharmacy director and pharmacy specialist. The reason, the Medicaid program, about 31% of the expenditures within the managed care program are drugs and pharmaceuticals and gene therapies. And it's in the 7 years that I've been here, it's almost doubled in terms of that. And I think in the private sector, you see all these commercials on TV about all these different drugs that are out there. That's one element of it, but there are a lot of unique gene therapies and cell therapies that are coming available that can really, particularly with children, deal with conditions that change the trajectory of what types of support they need in life. I don't know if Peg or Lisa here. Okay. Slide 4 is a brief overview of what we do. We oversee the managed care program that delivers the services and the various service lines that are available. Probably most notably as we describe everything other than Medicaid expansion, which is the Granted Advantage Healthcare Program, is what we call the standard Medicaid program, and then there's the Granted Advantage Healthcare Program. As I mentioned earlier, we deliver those and oversee those parts of the program, but we also work with the other divisions for the Medicaid services that they provide. There's financial eligibility, which Ms. Hebert's division oversees the administration of. We help develop the policy and collaboratively with them to administer that based on state and federal rules. And then secondly, with respect to eligibility, there's also for like long-term care, there's also, and home and community-based services, there's also medical eligibility, which comes into play with the Division of Long-Term Services and Support. So Melissa Hardy, who heads that, Karen and I work very closely together in making sure that the Medicaid eligibility, the delivery of the service are accomplished. I also included a slide 5. We had, I think, members of Division 3 and maybe HHS may remember if you were here last year that there was some discussion about how long of a procurement we would go through and along with the discussion around the reauthorization of Medicaid expansion grant advantage healthcare program. This is just highlighting the new procurement time frame that was put in place and also some of the key features that were added to or revised as part of the new managed care program. Slide 6 are policy matters that may be of interest to either Division 3 or HHS that you'll probably hear about this session. One that is, I think, a carry forward from last session is the disproportionate share program and the Medicaid enhancement tax program that was one of the last items that was dealt with last session, but not fully. And I expect that we'll see legislation in this session. Medicaid to Schools program is another program that we administer. I know we're working in this next year to address how schools do their claiming for the Medicaid match. We believe there's a greater opportunity in that space, which could help school districts and local communities receive more dollars for the services that they provide that are Medicaid eligible. The method that New Hampshire is using today sunsets federally in June of 26. So we applied for and received a grant to help facilitate that transition. And we're currently in a request for proposal. We have proposals in that we're evaluating for technical support to help make that transition so that schools can continue to claim and hopefully be able to claim more for the work that's being done there. Slides 7 and 8 are some views on enrollment. I won't go through it in detail, but would say that one of the key issues that we talked about last session was the federal public health emergency and continuous Medicaid enrollment. Our rolls grew to over 251,000. Today they're just over 184. They've been fluctuating between 182 and 184 over the last number of months. But you may have heard of the concept of the unwind, which is when the public health emergency ended, we needed to go back, and this was a big task and big lift for Mrs. Hebert's division in terms of reprocessing eligibility and doing the verifications that go with that. We were one of the first states, one of the first 4 states to be able to begin that process and one of the earlier states to finish it. And in terms of pharmacy, I think we hope to see some legislation this session about how we can acquire drugs within the Medicaid program more cost effectively than we do today for a cost savings, which I hope would be well received by Division 3. We last session implemented the Medicaid provider rate increases, which I've been in healthcare in New Hampshire for more than 30 years, and they were the largest increases that I think that Medicaid has received in my lifetime in Medicaid and in healthcare in New Hampshire. But we've completed that process. The legislature, obviously, you all know that Granted Advantage was reauthorized last session till 2030. Adult dental was implemented last session. We really appreciate both HHS and Division 3 for their support and working through the issues there. The program, I think, is continuing to build and strengthen, and we'd be happy to provide periodic reports to the committee and let you know how we're progressing. One of the waivers that the state has is called an 1115 waiver. What that does, and it was renewed in July of 2024. What was renewed component was inpatient substance use disorder and inpatient psychiatric care. The federal government had an opportunity for the state to draw a higher match on those services, with the understanding that we would use the additional money to maintain our community base and strengthen our community-based services, which a lot of that has, like our mobile crisis service, and I'll let behavioral health talk about what they're doing, but there have been a lot of things that have been strengthened in our mental health system to prevent boarding and to allow services to happen within the community as opposed to institutional. A new thing that was, if you will, generated from discussions with the Department of Corrections was to be able to provide what we're calling community reentry services for adults. What that initiative is intended to do, today there's a federal exclusion for paying for any services behind the walls of a prison, and except for an inpatient admission at a hospital. What we've been authorized to do here will be something that will be of benefit to our correction system, both at a state and county level. Ultimately, we'll be able to provide a limited benefit for people who have mental health disorders and substance use disorders to make sure that the transition from behind the walls to the community, that there's a carefully planned transition operated through a collaboration between the Department of Corrections, or SYSC to start with. We began January 1st in implementing this at those two levels, and we'll be moving to the counties. We've been meeting with each county to understand where they are. But for sentenced individuals, when they're released in the community, that they'll have the medications that they need, that they'll have their doctors or other providers situated, that they can actually have some intake appointments behind the wall, so that the data that the Council of State Governments has found about New Hampshire, a lot of recidivism in our county and state system are people who have unmet healthcare needs. You know, they're hit the street, they need either a psychiatric medicine or a medicine to treat their substance use disorder. And if they don't have those things, you can end up in our emergency rooms, which is the most expensive place to do it. And so this initially came from Commissioner Hanks in terms of asking us to apply for it, and it went through the process of approval to be able to apply. Then also Congress in 2023 for youth are requiring all states to implement a limited benefit program as well for individuals who are children, or up to 21 or up to 26 if they're former foster care. And it's a little bit different than the adult program, where it's not just limited to substance use disorder and mental health conditions, but to make sure that the types of things that you'd want to see a child have preventative screenings for, et cetera, that their healthcare needs are identified before they leave the setting, that again, that they're plugged into the community system. And an additional feature is that there's care management for 30 days after they leave that setting, to be able to make sure that not only were the things set up, but they're actually happening. We've also are working on implementing from the last couple of sessions, the omnibus provisions that were the doulas and the lactation consultants. We've already implemented donor breast milk. We're having to work with the Office of Professional Licensure on doulas and lactation. I'm going to skip the slides on enrollment and just jump to the slide that has the colorful picture of pink and green here. I see this page number didn't make it on there. but that is what I call our waiver wheel. This sort of describes the entire Medicaid program, both what we oversee directly within the division, but also the other parts of the department, whether it be in children's and youth services, behavioral health, what have you, adult services, long-term services and support. But we sort of work with those divisions and getting these things in place federally so that the services can be claimed for under Medicaid. And lastly, sometimes we'll talk about different match rates federally, and this is just a table on slide 10 of the different match rates that we get on different services. Again, if you have questions on the table, be happy to take them either today or at any time. Medicaid is a complex program in its details. It's simple, I think, we basically are supposed to provide a health insurance service under the Division of Medicaid Services through the managed care program. After that, it gets a little deeper and thicker, but be happy to, at any time, either one-on-one or come to the committee and provide additional information.
Thank you. It's my understanding, and I think, again, going back to my years in the department, Medicaid is roughly 70% of the department's budget. Is that correct?
I think that is probably in the neighborhood. I know that the department's about 53% of the state budget, and I think we're probably at least 60% of the department's budget.
I also noticed that New Hampshire Medicaid enrollment is fourth smallest in the country. Is
Yes.
that attributable to the unwind effort, or?
No, before the unwind, we were fourth smallest. During the unwind, we were fourth smallest, and today we're the fourth smallest. The different states have different federal match rates for their Medicaid program. Federally, like Mississippi, I think their match rate on standard Medicaid is 82%. New Hampshire's is 50%. Massachusetts is 50%. Both Maine and Vermont have a little higher than New Hampshire, and it's based on the federal formula of the economic status of the state as a whole. And while New Hampshire is one of the more affluent states, we all know that there are people who are not affluent in the state. Just to give you some statistics, New Mexico during the pandemic had 1 in 2 people in that state enrolled in Medicaid. By comparison, New Hampshire was about 1 in 5.5. Today we're about 1 in 7, but our neighboring states like Vermont and Maine are closer to 1 in 4, 1 in 5. So we have fewer people because of the economic status of the entire population in New Hampshire, which makes us the fourth smallest in the country.
So that's a good thing, I would say.
Yes.
Yeah, good, great.
And we also have, our eligibility criteria are as generous or more generous with respect to the various groups that we cover.
Great. Representative Weber.
Thank you, Mr. Chairman. Thank you for being here today. I just wanted to comment that possibly as an offshoot of Representative Edwards' comments or questions, I have had a number over the years of constituents who have had truly emergent issues of supplies they need or caregivers that are unavailable that were very desperate. And I try not to abuse the privilege, but I just want to say that anytime I have referred that to you, you have immediately found the right person to set it right and to ensure that that constituent went on getting the services they need. And I'm very grateful to you and your department for doing that. So I just wanted to note it.
Thank you for saying so. I would add to that, when we were talking earlier about eligibility, when the managed care system isn't living up to what we need it to do in a particular situation, that's where my division, I have 2 people that are clinicians who can help sort of size up a situation clinically. So I may be working with Karen's team on that issue because there may be elements that are not just financial or criteria, but real medical needs. And also Dr. Ballard, who's the medical director for the department and the Medicaid program, have access to him as well. And, we try to be helpful. There are situations that are very concerning and at times, and we will jump on them because we need to.
Representative Woods.
Thank you, Mr. Chair. At the risk of jumping down a rabbit hole, which I don't want to do, but just a very superficial comment. Do you have difficulties with PBMs and your pharmacy area?
I would say that it's very different than what the population at large is experiencing because Medicaid, we have a different relationship than the typical commercial insurance with the PBMs. Each of the MCOs have their own PBM, but like all these issues around like price transparency and things like that, we have that issue solved within the Medicaid program. We get different discount levels as a Medicaid program. I think one of the things that is happening out there that is similar to the rest of the healthcare market, if you will, is that narrower networks, managed care organizations at one time had relationships with all pharmacies, and now, for example, they may be with Walgreens but not with Rite Aid or whatever. And so we see that issue also. I think that the issue of different financial factors playing in with the transparency that we get, we're not experiencing some of those issues. I think our other issue, I guess that's common to the rest of it, of the population and maybe somewhat unique, is all these gene therapies for rare diseases that come through. And I can tell you that, for example, one rare disease, that Duchenne dystrophy, we've had since that therapy was available, a few instances where we've had to do it, but that therapy alone, which actually effectively cures Duchenne dystrophy in a way that the child has a normal life, costs $2.6 million. And so, when I started working in the program, we'd have one or two of these types of therapies come available each year. Last year, 66 potential therapies of that nature were available. The velocity of breakthroughs in that, the Medicaid program, I think, can experience more of that because some of the individuals that end up in Medicaid are because they have rare conditions. And so if you go back to that page 5, one of the new features in the program, the second one down, was a high-cost pharmacy risk pool to make sure that the managed care companies are better aligned with us in terms of how we use these therapies. We've created a greater sharing of risk around those unique therapies. We just initiated that in September. But the goal of it is to make sure we have appropriate utilization, that there's important follow-up that occurs so that the therapy is selected and used in the right instances, and that the hospitalization and other things that go around these therapies are done well, so that the investment that's being made is realized in a positive way for the patient and the state.
Other questions? Yes, Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So you have a nice chart here on the back about the federal match rates. I would be interested if you could just kind of paint with a broad brush where we are with our reimbursement rates on Medicaid relative to some of our neighboring states. Are we high? Are we low? Are we in the middle?
Thank you for the question. So HB 2 2023 made a significant investment in rates. We were very low. But with that legislation, I think we were able to get a lot of our services in the home and community-based services and the long-term services competitive with other states, and in certain areas where we benchmark with Medicare. I think where we still have room to do better is with physicians, and there were increases there, but where we're striving to do is to get to at least 80% of Medicare, and in a number of places we've achieved that. As part of the Met-DISH arrangement that Governor Sununu and Commissioner Weaver worked on last session, hospital inpatient rates are now at Medicare type levels. And under the Medicaid program, we're not supposed to be generally reimbursing more than Medicare. So that's why we're looking to get to 80 to 100. We're most of the way there, except in a couple areas.
And is that in line with the other states surrounding us pretty much?
I think in terms of, if I look at Massachusetts, Maine, and Vermont, I think we're probably in the middle of all those, I would say at this point, or maybe a little bit better than that.
Thank you.
Representative Lamontagne.
Thank you. I'm new to this committee, and I'd like to get a big picture understanding of Medicaid funding and to understand the waivers. Are we given an amount of money for I said Medicare, but I meant Medicaid, that is intended for the insurance component, and then we apply with a waiver to direct that into another program instead of leaving it in the insurance component? Is that how it works?
Great question, but not quite.
Okay.
So it's a federal state partnership. And so if you think of just the pure medical insurance, each person, like you would in a private situation, has a premium associated with them. We call it a capitation amount. And based on which group they fall on this chart, like if they're expansion population, the feds will give us 90% back. If they're a standard population, they'll give only 50% back. If they're a child, what we call the CHIP program, where New Hampshire provides a more generous level of eligibility, the match is 65%. So that's how the medical insurance part gets paid for. If you kind of think about Medicaid historically was just a categorical program, meaning like the aged, the blind, the disabled, developmentally disabled, long-term care, you had to have a categorical kind of thing to qualify. So the waivers are intended to provide extra services, and they provided outside the managed care program, like nursing home care, as an example. The home and community-based services that are long-term are outside the managed care program. We provide home care for short-term acute phases within the Medicaid program. And again, it works with what services are delivered and billed for that the state picks up. Typically, they're a 50% share, and the feds pick up the other 50%. So on a monthly basis or quarterly basis, we're accumulating all these bills, if you will, going back or capitation payments. And there's a special form that we file with the federal government to prove that we've paid this amount of money, and then they send us money to match that.
Okay.
Follow up?
Yes, just one follow-up. So by this chart here on the last page, the Granted Advantage, that's a managed care that's privatized.
No, it's delivered through our same managed care organizations. It's just, Congress federally had in encouraging states to offer it to people who don't fit a category other than poverty, that they could get insurance. And obviously it was that program, I think 41 states now have adopted it. There are, federally, there are discussions about what might happen in the future there, but New Hampshire is one of 9 states that has a trigger that if the federal match changes, that the program would be sunset. And we also have that larger 7-year reauthorization that the legislature has moved from 2 years and 2 years to 5-year, and now a 7-year possibility to operate the program without a reauthorization.
Representative Polazov and then Representative Edwards.
Thank you for taking my question. I wonder if income cliff is an issue for Medicaid, and generally, do you have any ideas how we can address income cliff situation when a small increase in income can cause a sudden loss of public benefits that include Medicaid or other benefits from the HHS?
Sure. There are other people who can speak. I think Karen Hewitt's division of economic development. They've been working with Chris Santinello, the associate commissioner there, on the cliff effect, and there've been work that the department's done. I've not been directly involved in that, but one of the things we do in our New Hampshire Medicaid program is that people who may go over the cliff, but who we recognize are eligible for the ACA coverage on the exchange coverage, that we do make referrals automatically for that, where the people have the opportunity to consider if they qualify or want to buy into that program.
Representative Edwards.
Thank you, Mr. Chair. Follow up to Representative LaMontagne, I think. The Medicaid issue is extremely complex, and we've not begun to coordinate with Mr. Lippman the Division 3 presentation that Medicaid delivers to us. But rather than deal with numbers this time around, I really want to teach Division 3 as much as we can about the Medicaid program. And when we schedule that with you, I'd like to open an invitation to HHS for anyone that wants to sit in on that, because I expect that to be more educational than really financial. So that's just one thing. And to Representative McLean on Medicaid reimbursement rates, Division 3 looked at this pretty seriously last budget cycle. The governor's budget had proposed something like a 3%, 4%, I forget the exact number, of increase to Medicaid reimbursement. And based on testimony we received and looking at the trend, we saw from like 2010 to the current time that we had bled year over year over year, falling a little bit further behind in Medicaid equity. And so we found the money last budget to take another 10% and invest it around in the Medicaid services to try to bring them back up to be less competitive. This budget cycle, I am having a very hard time imagining a scenario where we're going to be able to do more than what the governor may propose, and we may not be able to even do that. So if that's your issue, it's going to be a tough budget.
Thank you. Other questions for Mr. Lippman? Seeing none. Thank you, sir.
Thank you.
The next speaker is Ellen Lapointe.
Good afternoon, Mr. Chair and members of the committee. My name is Ellen Lapointe. I am the CEO of New Hampshire Hospital, and I have some other individuals who are here with me today who would also like to introduce themselves. But before we do that, I also wanted to mention that I also support Glencliff Home.
Thank you.
Thank you. I'm Brett Mason, Chief Financial Officer of New Hampshire Hospital, as well as the Glencliff Home.
And I am Cynthia Babonis. I am the Chief Community Integration Officer and liaison for New Hampshire Hospital to the legislature.
Thank you. Welcome.
Thank you. Thank you for having us. I just wanted to share some brief information regarding New Hampshire Hospital and some of the things that we have been working on in the last year or so, and happy to take any questions that you may have. Before we do that, I did also want to mention that the Chief Medical Officer, Dr. Jeff Fetter, also intended to join us today, but was unable to do so. So he sends his regrets, but I'm sure that there will be an opportunity that you can see him at a future time. In terms of a sort of a high-level review of New Hampshire Hospital, we are the state's inpatient acute adult psychiatric hospital. We have a capacity for 185 patients, of which is our current capacity. About a year ago at this time, our capacity was closer to 142 patients. Thankfully, in the last year, we've been able to bring on our additional beds to reach our full capacity just last month, actually, in December of 2024. We have 9 units. They are all approximately between 24 and 30-ish beds. There is some variation there. All of them serve similar populations in terms of serving the most acutely mentally ill individuals in the state. We do partner with what are called other designated receiving facilities, or DRFs, in the state. Those tend to have a capacity of between 10 and upwards of 14 to 16 beds. Those are more community-based, of which they go through a certification process under DHHS to achieve that DRF designation. And we partner with them to try to ensure that the patients who come to us for admission go to the location that is most appropriate to provide their care, which would then allow New Hampshire Hospital to serve the most acute individuals in the state. In the past year, we've also been an integral part, you may be aware of or heard of Mission Zero and Care Traffic Control. Mission Zero is the department's efforts to eliminate ED boarding of individuals who are awaiting our level of care in the state of New Hampshire. I am proud to say that on 4 occasions recently, we have achieved a queue of 0 adults waiting in the state. Those have been through very collaborative efforts of multiple stakeholders in many different areas of the state. But I mentioned Care Traffic Control. CTC has really been a driving force in being able to make those accomplishments and minimize some of the wait time that has previously been the case for these individuals. CTC is part of our admissions department at New Hampshire Hospital. And in the past year, they have become really the central intake of all of the IEA, or involuntary emergency admissions orders throughout the state. Before that, it was parsed out to basically every single DRF to kind of handle independently. Today, actually, the 16th, is the 1-year anniversary of standing up the Care Traffic Control Department. We are really proud of all the work that they have been able to accomplish and celebrated them a bit today. I'll hand it over, unless there's questions for me, which I'm happy to address, to Cindy Babonis, who will share just a bit more information.
Representative Weber.
I just wonder if you would touch very briefly on one of the things we have heard a lot about in the past is not only the issue of admissions, but the issue of timely discharge. And I'd love to hear just a little bit from one of you about where you are with that particular part of the puzzle.
Thank you, Representative. That is a wonderful question and exactly the direction that Cindy was going to go.
Okay, thank you.
Representative McKay had a question also. Oh, is that for Ms. Lapointe or?
It's connected, I think, to the question you already have, and that is about the borders, which means that people get to New Hampshire Hospital through their local hospital. Because of the lack of bed capacity, those people are put into essentially a room, maybe a TV. There's no treatment for them, and sometimes they had been staying in that hospital for days at a time. I understand that this has changed, and I would like everybody here to know that there has been very negative attitude about the hospital because of that. It's not your fault, and I know that. But I'm curious as to what you've done to, I think, solve that problem.
So thank you, Representative McKay and Representative Weber. To your questions, we haven't quite gotten to zero consistently in the queue, and that is directly related to how our beds are currently utilized. And so at New Hampshire Hospital, we do have quite a few patients, a percentage of our census that are patients that are stable for discharge, and they more than 15 days, sometimes for months, before we can discharge them. And that is related to resource shortages in the community at lower levels of care. And so to that end, one of the initiatives of Mission Zero does include looking at the back door at New Hampshire Hospital and reviewing that population in collaboration with the Community Mental Health Center system and the Division of Behavioral Health, the NAMI. We have a work group that is scheduled for our first meeting on January 30th to address those issues, to talk about what are the system-wide resources required in order to bring these people out of the hospital into the community, and even process efficiencies that we can implement in order to expedite discharge planning and help our patients be discharged from the hospital as soon as they're clinically ready to go.
Other questions? Seeing none. Oh, Representative McGrath, no, okay. Any other questions? Okay, thank you.
Thank you.
Next up is Meredith Toulouse. Good to see you again, Ms. Toulouse. It's been a few years. No, now
There we
it's
go.
on.
Okay. Good afternoon. It's very nice to be here. My name is Meredith Toulouse. I'm the director of the Division of Program Quality and Integrity for the Department of Health and Human Services. And I am joined by the director of our Bureau of Program Quality, Susan Drown, and our director of our Bureau of Program Integrity, Tasha Blanchard. Not here today is the head of our Office of Internal Audit, Teresa Narrow, but I'll describe some of the functions that she performs for our division. So our division is getting somewhat tenured at this point. We're about 4 years old, and we were created in order to, many of the functions within the division already existed, but we were created in order to bring those together under one roof so that we could coordinate amongst each other all of the support that we offer across the department and strengthen some of the support that we offer across the department. We are really a support entity. We support all of the other programs within the department in one way or another. So originally it was largely focused on Medicaid, doing a lot of quality work and quality metrics and Medicaid program integrity, and also SNAP for our SNAP program, a lot of support there, but we've expanded over the years so that we support programs across the department, both in things like data analytics, quality, performance metrics, and also in integrity functions like audits, internal audits, and external audits and reviews. So that's a high-level overview, and then I'll ask Susan to describe a little bit more detail on what happens in the Bureau of Program Quality.
Sure. Good afternoon, Susan Drown. I'm the director of the Bureau of Program Quality, and it's our Bureau's mission to provide data-driven support across the entire department, and that's with the aim of informing decision and policy making, as well as providing support with quality management and performance improvement activities. So we do that by leveraging the skills of our staff across 5 work units. We have health services assessment, contract quality management, data analytics and reporting, Medicaid quality program, and then substance misuse prevention and evaluation. And just briefly, 2 of the primary activities that we do is for Medicaid care management data. We do data collection and reporting to ensure that our New Hampshire citizens who are receiving Medicaid have access to quality services. And then we also work across the department to provide standardized methods of contract quality management with regards to active contract management. And through that, we also look at
performance metrics, those areas that we have contracted for that are desired outcomes and the standards. And for those areas that fall below that, we help develop quality improvement plans and activities to raise those standards. There you go.
Hi, my name is Tasha Blanchard, and as Meredith said, I'm the director of the program.
Could you speak up a little more?
I'm the director for the program integrity, and there are 6 units under the program integrity, but all of the units do reviews and investigations under the different programs within DHHS. We also are considered subject matter experts as far as compliance goes and regulatory, and we assist many of the program areas when they're developing their new programs, their new rules or whatever, to ensure that there is compliance in those programs and benchmarks that are manageable and accountable. We also assist with many of the programs in any kind of financial reviews they may have of their vendors, their providers, and any contractors. So and we also make sure that the programs are doing what they're required. We manage a lot of the federal audits that come in, and we work very hard to make sure that DHHS addresses corrective action plans and that we fix the problems that are found in any of those audits. And we've done a very good job in that we've reduced the single audit findings from about 14 down to 4. And so we're very proud of that effort that we've put into that.
Is the investigations unit still under you?
Yes, it is. And we are under the 10% backlog
Oh,
as
wow.
of last month.
How did you ever do that?
A lot of hard work.
Sure, I have no doubt.
We have an incredible leader in that unit now, Lindsay Bebo, and she and her staff believed that they could do it, and we didn't voice any disbelief, and they did it. It was really a remarkable achievement.
How many investigators are there now?
I think we have 7 now.
Okay.
And 2 claims.
And 2 claims.
Okay.
Yeah.
Great.
That's right. So the Office of Internal Audit is headed up by Teresa Narrow, who couldn't be here this afternoon. But they do a lot of internal reviews exclusively. So can internally look for management at, issues of compliance or efficiency, effectiveness, whatever kind of management review needs to be done. If there are, they take in referrals for fraudulent and unethical conduct across the department per our fraudulent and unethical conduct policy. They would do an investigation. That's not personnel investigation. They would just do an investigation for that fraudulent or unethical behavior. They also work to beef up internal controls across the department. That includes policies, procedures, communications, training, all that kind of stuff, but it's really internally focused. So you might think of like an ombudsman's office. They do things with external stakeholders and they can do reviews from external stakeholders. This is just internally focused.
Okay. Thank you. Any questions, Representative Edwards?
Thank you, Mr. Chair. Ms. Tellis, I think it's a little over 4 years now since I think we first started talking, and I've been intrigued by your program from the very first presentation. I think we talked about the capability and the limits in your capability of your office. And as I remember them briefly, it was that you are focused, as you must be, at coming up with benchmarks and quality measures for our contracts. But at the time, you had not had the capacity to take a look at departmental internal benchmarks. And so we had a discussion about it, and I think please come up with a 10-year plan so that we can have benchmarks for all our departments. You know, if you can't measure it, you can't assure that you're doing it right? And so, so that was 4 years ago. I'm just wondering if you remember, and if you could give us an update on where you guys are at having benchmarks for our departments.
So, sorry, I have a large light in the way when I'm trying to see you. But I also want to use the microphone so everyone can hear. So a couple things. One, yes. So the contracts quality management unit, which was probably non-existent the first time we had that conversation, is now up and running and actually staffed with 3 individuals. So they are working across the department with program areas to really beef up the way we write our contracts and the way we think about our contracts, the way we write our contracts, and then the way we manage our contracts so that we can consider those kinds of performance metrics, which really, though they exist in a contract, they are our program intended performance metrics, right? They're the deliverables we need as a department in order to be sure we're accomplishing our strategic goals. So that is up and running, and they're starting to work with various program areas across the department and create all kinds of templates and tools that can be leveraged even when they don't have the capacity to work directly with someone. As far as more department-wide, programmatic goals, I think one thing you and I talked about was kind of inputs in and then outputs that you get from that. And that, from a department perspective, is extraordinarily difficult because, as we discussed, we have hundreds of pieces of legislation that impact us every year. And those require all of our inputs that are doing other things to incorporate then these new goals and things that we have to accomplish. And so then the things that you were measuring are either no longer being measured, or you need to measure a whole bunch of new things because things change so rapidly. So the metrics that we have prioritized are the ones in the commissioner's roadmap. And those metrics include a few different areas, and that way we can link them with our strategic goals, our budgetary inputs, and where we're trying to get between us and our contractors at the same time. And so those are split into 3 different areas. We've got kind of internally focused things, investing in people and culture. We've got our community focus, so that's where the contracts come in terms of programmatic outcomes. And then we've got improving customer service is the 3rd leg of that roadmap, and that's improving things like our contracting process, so that the people we are contracting with can see those improvements. So there's sort of functional goals in there, and then there's also programmatic strategy goals, and including like improving the health of women and children that are in there. And those have specific targets and deliverables in that roadmap that are attached to numbers, specific numbers. Yep.
Follow up.
I've always been impressed with your way of thinking about this and what you're doing, and so once again, I come away confident that you're doing it right. I love the idea that you've prioritized the commissioner's strategic roadmap. What I think I'm going to ask you to do is to bump you to the front of the Division 3 hearing line so that you can walk through the roadmap and tell us what benchmarks or measures we should be anticipating as we hear the rest of the budget.
And I'm sure the commissioner and Nathan White have that in mind, but I will definitely bring it up.
I just hadn't asked my LBA to do that.
Yep.
So,
Oh, great.
Okay, thanks.
Yep. Thank you.
Other questions? Seeing none. Okay, thank you.
Thank you.
And next up is Melissa Hardy, who is right here. Hi. Long-term supports and services.
Here we go.
There we go. My husband's IT. He would have told me to unplug it and plug it back in, see if it works. So thank you, John. Good afternoon. I'm Melissa Hardy. I'm the Division Director for Long-Term Supports and Services. Our division, LTSS, promotes the health and well-being of people and their families throughout the lifespan. So you hear me talk briefly about services that we provide to children, youth, adults, and people who are aging. the majority of our programs are focused on home and community-based services. So providing services through provider agencies that allow individuals and families to remain at home or in the community that they prefer to reside in. In our division, we have three distinct bureaus. First, I'll start with what was formerly known as the Bureau of Elderly and Adult Services, which is now rebranded and named as the Bureau of Adult and Aging Services. We changed the name in July of 2024, and we moved away from the word elderly. When we talk about people who are aging, and I have a little pin here that we all wear, it says aging, everyone's doing it. And looking at research and, working with our partners along with the state plan on aging, the word elderly has a negative connotation to it, and we're all aging. So we were happy and proud to adopt that language change for our Bureau. And again, that was in July of 2024. And we know New Hampshire is an aging state. It's projected by 2030 for over 1/3 of the state to be over the age of 65. So we're really looking at shifting how aging is perceived in the culture of the aging services. In HB2, we were given an investment in the system of care for healthy aging that I think a lot of you were a part of, and so thank you for that, which established and implemented a comprehensive and coordinated system of care for healthy aging. It enables adults and adults with disabilities to have meaningful choice in the ability to receive the care when and where they want it. So that is in part of the commissioner's roadmap that you'll see that she presented on earlier as one of our strategic priorities. Also, in the Bureau of Adult and Aging Services, we have programs and services that we fund provider agencies to provide on our behalf. Most of you are aware of our Medicaid waiver program under Aging and Adult Services, the CFI program, the Choices for Independence waiver. It's a Medicaid waiver for individuals who meet nursing home level of care but prefer to receive their care in the community. So we administer that program along with our case management agencies and provider agencies through the Medicaid waiver. We also provide funding for nutrition programs, so Meals on Wheels and congregate meal programs. In 2024, we funded meals for over 2.4 million meals in the state of New Hampshire to over 15,000 unique individuals. Some interesting feedback from nutrition services, and I think one that hits me when I see it, is that 41% of people who receive Meals on Wheels say the Meals on Wheels driver is the only person that they will see all week. So that's very important. It's more than just a meal delivery service. It's really, it can be a welfare check on folks, and they're really eyes on to the people that we serve. So it's a real value add service for us. Another service that we provide funding for with our service providers is transportation. So we funded about over 120,000 individuals with transportation routes throughout the state. And that was, transportation to medical appointments, grocery shopping, congregate meals, banking, things like that. Well, that's good. I think, as Henry and Karen alluded to, the Bureau of Adult and Aging Services also provides medical eligibility for nursing facilities and the Choices for Independence waiver program. So we administer the medical eligibility process for Medicaid. We also have aging and disability resource centers known as ServiceLink. We have 13 local offices throughout the state that provide person-centered option counseling, information and referral services, family caregiver support programs, kind of serving as a central hub for information for people who are looking for services for adults and people who are aging. And finally, in the Bureau of Adult and Aging Services, we have adult protection. So we promote the safety of vulnerable adults and identify and meet the needs of vulnerable adults to decrease the incidence of self-neglect and maltreatment. So in 2024, Adult Protective Services served about 6,100 vulnerable adults in need of protection due to abuse, neglect, or exploitation. The second bureau I want to speak of is our Bureau of Developmental Services, or BDS, where we partner with 10 area agencies, local area agencies, as well as Medicaid service providers who are enrolled in Medicaid to provide home and community-based services for individuals with a developmental disability and also individuals with an acquired brain disorder. That is also on the Commissioner's roadmap as system strengthening for the developmental systems services. In BDS, in the Bureau of Developmental Services, we have 3 home and community-based waivers. So again, we have the developmental disabilities waiver serving individuals who have a diagnosed developmental disability. We serve individuals on our acquired brain disorder waiver. And we also have an in-home supports waiver, which supports children living in the community with their family who have a developmental disability. Again, I mentioned our 10 area agencies. So we have a contract with our 10 area agencies who are really our eyes on and the backbone of the developmental services system. They provide person-centered planning, have been around for, I think, over 30 plus years, and are really a partner with the department in a lot of the change that has happened over the past 5 years in the Bureau of Developmental Services. We also have over 100 Medicaid enrolled community-based providers that provide services to individuals such as case management or service coordination, assistive technology, non-medical transportation, respite, community integration services that help people achieve more independence in all aspects of their life. And then lastly, we have the Bureau of Family-Centered Services. So the Family of Center Services identifies and coordinates supports that assist children from birth to 21 years old who have or are at risk for a chronic medical condition, disability, or special health care need, and their families. So that bureau really helps New Hampshire families and professionals with health information, care coordination, family support. You've probably heard of early intervention services. So for children birth to 3, includes intake, evaluation, family support plans, and transitions for any kids who might be showing a developmental delay with their developmental milestones. So we coordinate that service as well. My bureau chiefs weren't able to be here today, but I do want to introduce Melissa Nemeth, who is in the gallery over here. She is our legislative liaison for the Bureau of Developmental Services and the Bureau of Family-Centered Services. So I'm happy to take any questions. In what I handed out, it was contact information for key people in my division. So please feel free to reach out that way as well.
Any questions? I don't see any.
Great. Thank you so much for your time.
Thank you. Okay, next up is Katja Fox. From the Division of Behavioral Health.
So good afternoon. At the risk of blowing too much of the speakers, I'm trying to, because I know that I can't hear back there, so I'm hoping you can hear me by being right on top of this mic, coming in hot. So I am asking Jenny O'Higgins to join me. She is our division's legislative liaison. So I'm Katja Fox. I'm the director of the Division for Behavioral Health. Our division oversees community-based services for substance misuse, mental health services, and homeless services. And so you're most likely have or will be approached by people in your community who need these services. And there are many dozens of organizations that we contract with who provide those services. So your community mental health centers, your peer support centers, your homeless shelters, all of those fall within our division. We have a makeup, and I don't expect you to remember any of this. So I'm going to, I know you've gotten a lot of materials today. So we're happy to provide any information that you feel like you need today or at any point during the legislative process. And if you also knowing that you have constituents who will be seeking you out about these services. So we have a policy unit of which Jenny is a member. And then we have 4 bureaus that address those issues. So we have the Bureau of Drug and Alcohol Services, the Bureau of Mental Health Services, which addresses the adult population, the Bureau of Children's Behavioral Health, which obviously addresses children's needs, and then the Bureau of Homeless Services, which within the last couple of years has joined our division because of the what leads to someone being unhoused, and recognizing that our services are so critical to their supports. And you're going to hear a lot of buzzwords over the next 6 months. You're going to hear a lot of things that are referred to. They all are made up of those services, but we use as our blueprint our 10-year mental health plan. And that's available online. Be happy to provide it to you and get a link to you. And that was established in 2019. It's still very relevant today. And we have done an incredible job with the support of the governor and with the legislature to bring those recommendations and those services online. So that includes New Hampshire Rapid Response, which is mobile crisis, which is available in your communities. We also have a children's system of care, which is in statute, and that also lays out what's expected to have a robust children's system. We appear, you'll see particular priorities that appear in the Commissioner's roadmap, and we partner with New Hampshire Hospital and other providers that were mentioned by Ellen LaPointe in her discussion about New Hampshire Hospital. What I thought I would do, I'm going to have Jenny just explain her process. She is the front face. You're going to see her. And if you don't see her in your committee room, you'll see her in the hallway, probably texting me or doing some work. And then we'll also introduce the other members of our team who are among those who will be called upon to testify before you.
Hi there, I'm Jenny O'Higgins. I'm our legislative liaison and senior policy analyst in the Division for Behavioral Health. I work very closely across our policy unit with our director and deputy, as well as all of our bureau chiefs throughout the whole session, responding to providing information and weighing in on bills and completing all of our fiscal analysis, etc. So I'm absolutely available to you for questions throughout the session, and able to get back with those folks that are closely tied to the programming and find out questions around how those things are implemented or funded. So happy to answer any of your questions throughout the session.
Thank you.
And as I said, I have a few people here who I asked to join. We have a couple of new bureau chiefs. So this is new to them, but we wanted to make sure they're not new to the work, I can assure you of that. But we wanted to make sure that they got a sense of how you conduct your business, and they are the subject matter experts that Jenny will be leaning on to come in and provide information. So I'll just ask them to stand and wave. So we have Daryl Tenney, who is the Bureau Chief for Children's Behavioral Health. We have Carolyn Lewis, who is the Bureau Chief for Mental Health Services. And Jennifer Sabin, who is the State Opioid Response program director. That's something I know that you all have heard about and experienced in your communities, and she oversees all the programming around that federal grant. And I'm hoping I didn't forget anyone. Apparently not. So with that, again, we're here to help you help people, and we'd be happy to answer any questions that you may have again today and in the future.
Thank you. Representative DeLamus.
Thank you for taking my question. It's very simple. Do you have contact information or a sheet that you could pass out to us?
So I'm hearing from John Williams that yes, we do. Great. And again, some of the resources and materials are available online and could be made available to you as requested and as needed.
Representative McKay.
Thank you, Mr. Chairman. What I'm going to say is should not be viewed as a criticism of the department. I have a constituent, more than one actually, that called me. This particular person was in New Hampshire Hospital for more than 3 months, which tells you it was a very severe case because the actual time is 3 to 5 days, something along that. He was referred to a mental health center. He's been getting good care and medication. He feels tremendously the need for counseling. That there is no counseling for him in that mental health center. And I hear this often in terms of not only mental health centers. He was referred to 3 private groups, all of whom said, we can't do a thing for you for at least 6 months. Now, I'm sure you'll hear this every day. There's nothing new about it. What I'm concerned about, is there anything we can do to help out, to provide services? I know I'm just too old to go back and do that kind of work again. If I wish I could. But is there anything we can do for you to help these individuals who at the present time are not getting care because there isn't sufficient personnel to provide that care?
So thank you very much for sharing that personal interaction that you've had with a constituent. And we do hear that that is an area that needs improvement. Access to care is so critical, especially as people are seeking it. And so we're doing multiple efforts. We have found, as you heard in the Mission Zero discussion, that it isn't just one solution, it's multiple solutions. And so workforce, and not just looking at the workforce in having it people go to school, get certain degrees, and then enter the workforce, and we all get a little frustrated because that takes time. We're looking at expanding the workforce, and so who can provide services, who can be the person that is able to support someone in the community, and it may not always need to be a clinician, it can be a peer. And it can be communities. And how do we build communities to be able to support someone who's in need of those services? So you are going to hear a lot about this in the upcoming session. There are multiple bills to address this, but we totally understand. And anyone who is in our system deserves to have those services available when they need them. And it is all of our jobs to make that happen.
Other questions? Seeing none? Okay, thank you. Next up is Reuben Hampton. Good afternoon.
Good afternoon, Reuben Hampton, Director, Office of Health Equity.
If you could speak a little louder and bring it a little closer.
Good afternoon, Reuben Hampton, Director, Office of Health Equity.
Thank you.
My name is Elizabeth Maynard, and I am with an attorney with the Office of Legal and Regulatory Services at DHS.
The mission of the office is to help identify and mitigate health disparities for all constituents, in particular those from low-income backgrounds, those with disabilities, and racial, ethnic, gender, and other minorities. We do a lot of work to help ensure folks have equitable access to the benefits and services that the department offers. There are a few different functions of the office. In particular, there's communication access. We manage these services for the department. That includes interpretation, translation. We provide training internally, externally, vendors, partners, help them with their plans, help them get set up to provide services to their own clients. And we also provide support and community outreach and engagement. There are different grants and programs within the department that may need to reach out to specific populations that we can assist with. So we can connect them with some of those specialized populations. There are others that need education and aren't aware of all the latest information on some of the benefits and services the department offers, so we help facilitate those conversations as well. We provide training and resources on providing more culturally appropriate care so they can be more effective with the different clients and populations that they work with, and help troubleshoot different problems we receive outreach on, whether those are individual clients or other fellow state workers from different departments who are in need of assistance. We also have the refugee program that runs the office as well, so we administer a few different grants and work with service providers to ensure the refugees and other OR eligible clients who come over are able to integrate and achieve economic stability.
Is your office relatively, your division relatively new? I don't remember it from the past.
This office didn't have a director for 2 years between 2020 and 2022, so that could be why. I joined in February 2022 and I think missed this event prior, so it could have felt like 4 years.
Okay. And how big a division is your section?
11 currently.
11. Okay. Thank you. Representative Edwards.
Thank you. We've met several times to talk about your programs, and I want to just help your program out and help the people of New Hampshire understand what your program does, and what I think it's important for people to understand what your program doesn't do. I think the word equity has become politically suspect in many groups, and so with that in your title, I want to make sure that we're clear on what you all are doing. I think it's absolutely appropriate and imperative that we know our state demographics and that we're seeking ways to ensure that all of the demographics in our state have good, strong, equal access to health care, and that you're helping to identify barriers that may get in the way of that equal access. and you're trying to eliminate them, education and communication. So that's what you're doing, I believe. What you are not doing, and it's important for people to understand this, is I don't think you guys are looking to disproportionately advantage any demographic to get superior or front of the line kind of care. You're looking to make sure there's equality in the access. Is that fair to say?
I think that is fair to say, Representative.
Okay, follow up.
Follow up.
Okay, and then the other part of this that I think is in your Venn diagram is there's a lot of concern about the state spending money on the term that's used usually is illegal immigrants. And talking to Mr. Lippman and you and others, I believe that you have a strong program where you're making sure that any refugee or any non-U.S. born patient is run through an eligibility system to make sure they're here legally and that they're getting the services that between the federal government's authorizations and permissions and our own, that we are not giving out healthcare benefits to the gotaways, the people who really ought not to be in the country and who are hiding. So to turn that into a question, do you think that it would be fair to tell the people of New Hampshire that we have strong programs to make sure that those foreign-born people who are in New Hampshire are receiving authorized care, and if they're not here legally, in a legal status, that we have control mechanisms to prevent them accessing our services?
As you noted, the refugee program is a federally funded and administered program, so there are specific regulations on who can be a client. All refugees are vetted overseas. The limited categories of others who can receive benefits also have specific requirements, all have legal status to be here.
So again, I think you're confirming that we're positively giving care to those who are authorized under various programs. The question is actually the negative of that. We're also ensuring that those people who are not here under a legal category are prevented or blocked or disadvantaged to receiving care that they're not authorized to. We're not spending money on the gotaways. Hopefully that's a yes, kind of a simple yes.
For our program specifically, everyone is vetted. Yes. Yes, I am.
Other questions? Seeing none. Okay, thank you very much.
Thank you.
And last but certainly not least, Melissa St. Cyr was scheduled, but filling in for her is Attorney John Williams.
I can represent to this group that during my law school education, I did not make a living moving furniture, but I did the best I could just now. For the record, oh, that's right, this is not a legislative hearing, but I just want to thank you and Chairman McDonald and also Chairman Edwards for your participation today. Your attention over the last 2 hours and now going on about 10 minutes is really appreciated. Melissa St. Cyr could not be here today, so I am here just to identify some of the programs that she's involved with. Under Melissa's umbrella as our Chief Legal Officer, myself, John Williams, I'm the Director of Legislative Affairs, and I fall under her umbrella. And also with me today is...
My name is Catherine Bernhardt. I'm the Privacy Officer for the department.
Good afternoon. I'm Doreen Shockley. I am the manager of the Bureau of Licensing and Certification. I think I've met many of you in the past, and I'm sure I'll see you again.
And on to my right,
My name's Danielle Warboys. I'm the attorney for the Bureau of Licensing and Certification.
and so under the legal and regulatory services that Melissa ministers, we have our administrative rules unit, we have the Office of General Counsel, we have legislation, and we also have our wonderful licensing folks and our privacy officer. So you can tell that there's a lot of activity that happens within our legal and regulatory unit. And so I just wanted to thank you for the opportunity for this wonderful meet and greet that we had today. In my role and capacity as legislative director, very similar to what Jenny O'Higgins had mentioned to you as the legislative liaison for the Division for Behavioral Health, I'm involved with helping coordinating legislative activity for the entire department, but I work with many, many wonderful people. The legislative liaisons are subject matter folks. They're people who are attorneys like myself, who do an incredibly thoughtful job working with you. You're very thoughtful in what you do, the questions you ask, and the opportunity to be a resource to you on areas of developing policy for very important things that you heard about today. The other thing that I do is I do work along with Nathan White. If you don't know Nathan, you should. He is our Chief Financial Officer. He's identified on that wonderful, wonderful one-pager that we have with the contact information. But he's somebody who works very closely with Division 3, but he also works with our legislative liaisons and myself in developing the fiscal analysis on big bills that come before your committee, those bills that have greater than $10,000 in fiscal impact. And that's a sizable portion of a job that we do that you don't see here, that we're doing back in the office. We also, many of us work later at night, just like you do, getting the work done that needs to be done. And then finally, it is probably one of my most pleasurable parts of my job is getting an opportunity to work with you on constituent inquiries. I will say as over the years, it is something that is very rewarding when I see your constituents coming in our direction and we're able to help them understand the process and get those whatever services that they were eligible for. So it's been a long day and I really do appreciate your attention. The good news for you is you're not on Division 3 because they do the budget and many times they're here till, well, I can tell you, I've seen the sunrise at Division 3 during the committee conference on the budget. And I just really want to thank you and again, Chairman McDonald and Chairman Edwards for this opportunity today. My parting comment is the materials that were provided to you, and we need to get a few more out to you, are going to be provided electronically to you, all the materials today, both to the Health Human Services LD Affairs Committee as well as House Finance Division 3. You'll be receiving those materials either later today or first thing tomorrow. With that, we're looking forward to the opportunity of working with you. I must say, over the decade and a half, almost 2 decades of doing this, this committee has always turned out to be just a wonderful committee to work with. It's very collaborative under the leadership over the years, and I just want to again emphasize we're just looking forward to 2025.
Thank you. Attorney Williams, just to clarify, LNRS, Licensing and Regulatory Services, that's what it stands for?
That is what it stands for. And and what's amazing, you have a packet. It's a 56-page packet of 12 font size acronyms for the department. Each of you have received that, and they'll be part of your materials that we received today. One of the things that we work on in terms of clear communication with the committee is I do ask my legislative liaisons to refrain as much as possible from the use of acronyms because it is a very acronym-rich world we live in. I was favorably impressed that I didn't hear, I don't think, one acronym said by one of our staff testifying before you today. But if somebody does testify and start using a lot of acronyms, you either have your secret decoder ring or ask them to slow down and actually explain what that acronym stands for. Thank you.
Attorney Williams, I want to thank you for setting this up today and your coordination efforts and making this happen. It was very helpful. Again, thank you to everyone in the department for coming. And yeah, Representative, you have a question?
I wonder what work we're doing in the area of improving licensing reciprocity, especially in the nursing field and other fields. And also, whether and to what extent we're doing anything to, on the area of licensing to bring more retired nurses out of retirement, given the shortage that we have, not only in New Hampshire, but in general.
If I could just address, and I'll have Ms. Shockley right so that the public can hear. The two questions that were raised is what is the department doing around reciprocity on licensure? I'm going to just field that one very briefly. The Executive Department's Administration Committee, they have the Office of Professional Licensure and Certification that license a multitude of boards, including the Board of Medicines, which includes physicians. They also administer the Board of Nursing, Board of Pharmacy, a whole bunch of boards that are out there. So I would suggest to the representative that I would be more than happy to get them into contact with the executive director over with the Office of Professional Licensure to talk about what they're doing around reciprocity, because that's beyond the scope of our agency's work. We do not license individuals, professionals, but we do license facilities, and that's where I'm going to segue it over to Doreen Shockley.
So thank you for the question. It was an important question to make the distinction that the Bureau that I'm speaking on behalf of is for facilities, for all health facilities, nursing homes. We do the, but not the individuals. So we'll get that information. Yes.
There was another question? Oh, there was another, you said there was a question over here? Oh, okay, I'm sorry. Representative McLean, did you have something?
Yeah, just 1 second. Just quick. I noticed on the contact sheet, I was unaware of this position. You have a position of ombudsman and Office of Long-Term Care Ombudsman. I was unaware of those positions. Could you maybe let us know what their roles are and you know, the scope of their powers kind of thing?
Yes, and if Melissa St. Cyr were here, she would have not have missed, because under her umbrella also falls the Administrative Appeals Unit as well as the Ombudsman's Office. The Office of Ombudsman is statutorily created. It is under the Department of Health and Human Services, but they're specifically designated to be independent from the department. In other words, they're enabled to provide services to do investigations. Individuals who have constituent inquiries or concerns over services can certainly go to the Ombudsman's Office for assistance, and they serve a very important role for advocating on behalf of citizens of New Hampshire based upon concerns they may have with the department. Now, with that said, Representative McLean, I need to make a distinction. There is a second Ombudsman's Office. It's called the Long-Term Care Ombudsman's Office, and Sue Buxton is the Long-Term Care Ombudsman. They go by OLITCO. Here we go, acronyms, but by the Office of Long-Term Care Ombudsman. And they are specific to the area of long-term care. So we're talking over in Doreen's area that there's an overlap. So I'm going to turn it over to Doreen to talk to you about that other Ombudsman's Office and how her folks who work on licensure deals with the Ombudsman's Office.
Thank you. So we have a certification team. We are the state agency for the federal CMS, and we work very closely in our residential settings, nursing homes, and assisted living facilities with Sue Buxton and her team to make sure we're looking at investigations or allegations from the lens of the facility, and is the facility compliant with rules and regulations. The Ombudsman's Office is working from the lens of the resident or the patient, making sure that their needs and their are being met. So we'll often collaborate from both lenses to make sure that every individual is being served in the manner that they have a right to.
Any other questions? Representative DeLamus.
Thank you, Mr. Chair. This is more of a statement. Nice to see you again. As far as the ombudsman, I probably shouldn't even direct it to you, but to Representative McLean. I was in need of the ombudsman and had found out about that office years ago. And as a private citizen at the time, one of my relatives, I feel, was not being treated well and had broken ribs and a broken arm. And so I called the Office of the Ombudsman because I didn't know how to deal with it with the facility. And then they took that out of my hands, and the Ombudsman went in without warning and just checked on that patient. And I think that was amazing. And the treatment that my relative received after that was much better. So thank you very much.
Other questions? I don't see any. Okay, thank you very much. And we do have one more speaker. We have Rebecca Sky from the State Commission on Aging.
And may I, Mr. Chairman? And just so you know, Sue Buxton is one of the members of the Commission on Aging. So there's an awful lot of interweaving of people's hats and roles in all of this.
Yes. And I work down the hall from that office, and they do amazing work for a very vulnerable population. So thank you for your time today. My name is Rebecca Sky. I'm the Executive Director for the New Hampshire State Commission on Aging. The Commission on Aging was created during the 2019 legislative session with a primary charge to advise the governor and the legislature on issues related to aging, largely in response to our dramatically changing demographics to an older age population. So we are here to be of service to you. If you ever have a question about a particular policy point and its impact on all of us as we age, please reach out to the commission. If we haven't already researched the answer to the question, we will dive in and research. It's a 26-member commission of very engaged people. We have actually, we have one state senator, 3 state reps, 13 people appointed by the governor, and 8 state agencies represented on the commission. So diving more into why the commission was created, you have it's two-sided, but it's one piece of paper. It's the last 2 pages of our annual report. And on the side that has the graph, that's on at the bottom corner, says page 40, you will see data from I think it's the department, it's the New Hampshire Office of Planning and Development within the Department of Business and Economic Affairs developed this data, making population projections from 2020 to 2050. And this is for the population aged 65 plus. If you notice the dashed green line, that's the 85 plus population. And as all of you know, government is created by people, policymakers such as yourself, for the people in response to who the population is. And so that is why the commission is here to help all of you be responsive to these demographic changes that are happening in our state. So the 4-page handout, the one that looks like this, is the executive summary of our annual report. On the first page of this executive summary, the commission urges policymakers to see our growing older adult population for the opportunity all of us are. If you look around this room, that's us. Page 2 names the 4 overarching priorities the commission has identified for the state in response to changing demographics. We need to strengthen our systems of care for healthy aging. Prior to 2023, the last time the system of services for older adults was significantly addressed was actually in 1998, with legislation under the umbrella of Shaping Tomorrow's Choices. The work done during the last budget cycle to establish the system of care that Melissa Hardy referenced needs to be built upon during this and upcoming legislative sessions. One item in particular from House Bill 2 from 2023 was a call for a Medicaid rate study of home and community-based services and for the upcoming budget proposal to reflect changes based on that study. Hopefully you'll have an opportunity to review that soon. We also call for an effort to grow our direct care workforce that provides long-term services and supports not only in our nursing facilities, but in our communities and in people's homes. And under the umbrella of advancing age-friendly policy systems and environments, the Commission calls for efforts to create age-inclusive workplaces to engage our older workers. I think it was mentioned just now, how do we bring back our retired nurses? We need them. We also talk about ensuring that our new housing builds are smart builds and that they are age-ready with no barrier entries and bed and baths on the first floor. And that we foster civic engagement and make efforts to address social isolation among many of the other items that are named in our full report. Finally, we call for the development of a long-term vision for change, a roadmap of policy considerations to create the future that we seek. Many of the changes need incremental changes to build to them. We have branded this plan the Age Well Plan. Age Well NH Plan, excuse me. The plan is not yet created. We hope to engage all of you over the coming year to participate in its first in its framing and then eventually into its development. I do have copies of the full report in black and white, stack over on the table. I didn't want to overwhelm you with paper. The full report is organized to provide a case for the above-mentioned priorities areas and detailed recommendations in each of those areas. And it also provides highlights of progress made in recent years on these issues. One final note is that the Commission produces a newsletter called Aging Matters. It's edited by a member of the Commission and is published monthly. You will be receiving it in your legislative email address. It's really chocked full of information. Some of the articles do focus on policy issues, but there are other articles that are just valuable information that you can share with your constituents about state services, community activities, etc. And if you would like to receive it at an alternative email address, just reach out and we'll make sure you get it. So thank you, and I'm happy to answer any questions. There are two people here who are actually serve on the commission, Representative Weber and Representative McKay. We are very grateful for their participation. It helps to keep our work meaningful for all of you.
Thank you. Any questions? I don't see any. Okay, thank you very much.
Okay. I also want to mention that Representative Charlie McMahon also serves on the commission.
Okay, I have no other speakers listed today. So that will conclude the program. We will begin our hearings next week, starting at 9:30. We have a full day scheduled for next Wednesday and next Thursday. As of this afternoon, we determined we have 28 bills assigned to us so far, and more are anticipated. So we're going to get off to a running start next week at, again, 9:30 on Wednesday. Look forward to seeing all of you then. Thank you, Representative Weber.
I just had one nuts and bolts thing that I wish I'd asked at the beginning of last session 2 years ago, but I didn't. We have now become kind of a traveling committee. So do we still have somewhere an office that has filing cabinets where we can keep papers and things? And if so, which one is it?
I have not been told otherwise, so it should still be 205.
Okay, so that's our home
If
base.
that has been changed, then no one told me. So
Okay, thank you very
quite
much.
sure it is.
So for new members, they should have a drawer in a filing cabinet that has their name on it so that they could actually, I mean, it fit a pile of papers plus a pair of shoes. So it's very useful.
To the best of my knowledge, that should be the case,
Okay.
yes. Representative Palazzo.
I have a question, maybe to the chair. Does our committee have any policy on lobbying from agency? Because, for example, when Karen Hebert was speaking about testifying here in future, she told us that she will be giving us information. But when another agency lead, Ernie Gillen, was speaking about what he will be presenting, he made it clear that he will be advocating for certain policies from the agency. So as far as I understand, some committees advise agencies just to give information and not taking positions. So I wonder, like, if there any preference in this committee.
I don't know of any restriction on an agency advocating for a certain position. I know oftentimes Health and Human Services does not take a position on a bill. They just provide information, but on other occasions, they may offer opposition or support. And that's up to really the agency on a case-by-case basis. At least to the best of my knowledge, Representative Weber, I don't know of anything different than that.
I would say that, and I also would say that when I have subbed on other committees, I have been astonished at how very careful the Department of Health and Human Services has been to be clear about what are legislative prerogatives. And they certainly, I mean, it seems fair to me that they can have positions and communicate them to us, but they are also very clear that it is the legislature who makes the final decision on those. And I think that Mr. Williams in particular has been very careful to make that clear. I have been in other committees in other years some time ago when an agency has simply said to a legislative panel, well, we're not going to agree to that. And I find that that's where it's troublesome. So thank you.
Any other questions? We will be meeting in, and it's my understanding this will be our assigned room for, generally speaking, for committee meetings. Room 201, we'll be sharing that with Public Works. Public Works will be meeting on Tuesdays. We will be meeting on Wednesdays and sometimes Thursdays as we will be next week. So, and of course, everything will be noticed in the calendar. So unless anyone has anything else, any other questions? Okay, we stand adjourned. Thank you.
Mr. Chairman.